Let's start with anxiety disorders. Our sources tell us they're the most common mental health issue in Australia, affecting nearly, 15% of people, and they frequently show up right there, in your practice. What's often striking, though, is that despite this prevalence, they often get missed, don't they? Under-recognized. That points to maybe a deeper challenge. What are some subtle ways you think GPs might be missing these early signs?
It really does. Often it's that medically unexplained symptom that actually is the anxiety, not something else entirely. Patients might come in talking about a dizzy spell or chest pain or maybe gut issues. And after you've done the workup and ruled out organic causes, the underlying anxiety can still be overlooked. Early recognition is so vital because effective treatments are available, though, yeah, they do take time to work. A key principle our sources really underscore is that comorbidity is incredibly common. So, anxiety frequently coexists with other psychiatric conditions, think depression or substance abuse, even various medical disorders. Now, this doesn't mean we should be pessimistic about recovery, not at all, but it definitely shapes how we approach treatment.
That's a powerful point, looking beyond the obvious presenting symptom. So when a patient comes in with those kinds of varied symptoms, how do you recommend a GP starts that an initial comprehensive assessment for anxiety?
Well, the very first step is always just to let the patient describe their most concerning symptoms, in their own words. Then it's about systematically ruling out those underlying medical conditions that can subtly mimic anxiety. Our sources list quite a few common mimics, things like thyroid dysfunction, hyper or hypo, cardiac disorders, or even chronic respiratory disease. The crucial takeaway here is really making sure we've ruled out these great pretenders before firmly moving towards a psychiatric diagnosis.
That list of mimics is incredibly useful. Are there maybe one or two you find GPs most commonly overlook when they're thinking about anxiety, maybe leading to a misdiagnosis?
That's a good question. Interestingly, benzodiazepine withdrawal is one that can be easily missed if you don't specifically ask about it. Its symptoms can perfectly mirror a severe anxiety state. So once medical causes are excluded, the next step is to pinpoint the specific anxiety disorder. You need to identify a specific focus for the anxiety. Our sources describe a few key ones. First, there's generalized anxiety disorder, or GAD. That's the unrelenting excessive worry over just everyday matters. The key here is to shift focus from what they worry about to the act of worrying itself. Then you have panic disorder, recurrent panic attacks, and importantly, catastrophizing about their consequences. This often involves avoiding open or crowded spaces. That's the agoraphobia component. Social anxiety disorder, or SAD. This involves this excessive preoccupation with perceived criticism or negative judgment from others, often leading to significant social avoidance. And finally, obsessive compulsive disorder, OCD, characterized by recurrent intrusive thoughts, the obsessions, and those ritualistic behaviors, the compulsions. Importantly, patients with OCD usually recognize their ruminations as irrational, which helps distinguish it from conditions like, say, hypochondriasis.
Okay, so once we've kind of nailed down the specific type of anxiety, the next step is understanding its impact, right? How do we quantify the degree of distress and functional impairment?
Yeah, exactly. Anxiety checklists and self-report inventories are incredibly helpful here. They help quantify and track symptom severity over time. For general distress, our sources recommend widely used tools like the Depression Anxiety Stress Scales 21, the DAS-21, or maybe the Kessler-10, the K-10. For specific disorders, you've got tools like the Penn State Worry Questionnaire 3 for GAD, or the Mini Social Phobia Inventory, the Mini SPIN for screening social anxiety. The key is really finding a tool that works for you, for your practice, something you can use to track progress and objectively assess the patient's experience. And always, always remember to assess for suicide risk, especially if there's comorbid major depression involved.
Okay, so we've assessed, we've diagnosed. With that done, our focus naturally shifts to, well, what do we do next? Let's talk about those first-line management approaches.
Right. Management should always be collaborative and pragmatic. Psychoeducation is foundational. This involves explaining the nature and purpose of anxiety, how it presents physically and mentally, and really addressing that patient's worry about worry. Educate them on fear reinforcement cycles, how avoiding feared situations actually makes anxiety worse, and the crucial need to gradually confront those situations. In Australia, it's great that patients can access Medicare-funded psychological care via a GP mental health care plan. That's a really powerful tool in your hands.
When we think about specific psychological treatments, cognitive behavioral therapy, CBT, often comes straight to mind. But in the trenches of general practice, what are the practical realities of referring for CBT? And are there maybe particular patient profiles for whom it might be less effective, prompting us to think about alternatives?
Yeah, CBT is indeed extensively studied. It generally includes education, arousal management, things like relaxation techniques, graded exposure, and cognitive strategies to challenge those maladaptive beliefs. Now, while it's highly effective, the challenge in general practice can sometimes be access getting timely, high quality CBT. Digital CBT or DCBT through apps like Mental Health Online or MoodGYM, This Way Up, those can be really practical alternatives, kind of bridging that gap. Other approaches like acceptance and commitment therapy, ACT, and mindfulness also show promise, but CBT typically has the strongest evidence base specifically for anxiety disorders. As for when it might be less effective, um, perhaps patients with severe unmanaged comorbidities or maybe significant insight deficits might struggle to engage fully. That's something to consider.
Right. And when those psychological interventions alone aren't quite enough, or maybe for more moderate to severe cases, what's the pharmacological approach GPs should be considering?
Okay, so pharmacologically, selective serotonin reuptake inhibitors, the SSRIs, and serotonin noradrenaline reuptake inhibitors, SNRIs, are definitely first line. Examples available on the PBS include things like escitalopram, fluoxetine, sertraline. You're familiar with these. It's absolutely crucial, though, to start with a low dose and titrate up slowly, especially in panic disorder, because initial side effects can sometimes feel like worsening anxiety, which can put patients off. Benefits typically begin around 4-6 weeks, but the full effect can take up to 12 weeks. Patience is key. If it's effective, you'd continue for 6-12 months, maybe up to a year for GAD, and always discontinue gradually to prevent withdrawal symptoms.
What about benzodiazepines then? You mentioned withdrawal earlier. They have such a rapid effect, so why aren't they considered first line?
Yeah, our sources are very clear on this. While they do have rapid effects, they should absolutely not be used as first-line treatment. The significant risks are just too high. Tolerance, dependence, difficult withdrawal syndromes, rebound anxiety, cognitive impairment, plus a higher risk of falls and sedation, particularly in older patients. They are strictly restricted to short-term use, often just for acute crises, maybe to allow a patient to settle enough to engage with psychological treatment, and they should largely be avoided in patients who have any history of substance abuse.
That's a really crucial distinction. So beyond individual psychological treatments or medication, many GPs find themselves thinking about a multi-pronged approach. What are your thoughts on combination therapy, especially when you're dealing with those more complex or treatment-resistant cases? And how might that differ for specific patient populations, like older adults or perinatal women?
Combining CBT and pharmacotherapy is actually quite common, especially for more severe or comorbid presentations, or, when monotherapy just hasn't been sufficient. While it might lead to faster initial gains, the research doesn't consistently show long-term superiority over either treatment alone. And some experts caution it might even interfere with exposure therapies if not managed carefully. The medication might blunt the anxiety needed for exposure to work effectively. For special populations, yeah, perinatal women often benefit from CBT first line, mainly due to concerns around medication and pregnancy. But SSRIs or SNRIs can certainly be considered for severe cases with a very careful risk-benefit discussion. Older adults definitely benefit from CBT due to those polypharmacy risks we mentioned. And if medication is used, lower doses are often needed because they're more susceptible to side effects like hyponatremia.
Okay, let's move on to another complex